Hi, good afternoon, everyone, the esteemed panelists and the audience here. I have to admit a few things. This presentation partly was given yesterday, and I will give the rest of the talk today. But I'll just very briefly go through the first few slides, first half of this presentation, for in case there are questions. So the title of this talk is Quality Assurance of Breast Biomarker Assays in Immunohistochemistry, Adapting the Standards for Bangladesh Laboratories. So it has two parts, as you can see. One is talking about the quality assurance in general, and the second part is adapting these principles in the context of Bangladesh. And the reason why we were talking about Bangladesh specifically is one of the reasons is the breast biomarker assays that we do is quite critical for a large number of cancer patients here. So if your immunohistochemistry results are not reliable, it affects the patients, it affects the clinicians, it affects the oncologists. And so I don't know, is there any pathologist here other than Professor Khodeza? So no pathologists. So rest of them, I think rest of you are probably oncologists, surgeons, and radiation therapists. So it's a good opportunity to bring your attention to this because you are going to refer patients or samples to pathologists, and you will expect good reliable results. So I think it's also in your interest. You should look for laboratories that have good quality control standards in practice. Otherwise, the results that you will get will not be satisfactory, and if patients will go from one lab to another lab, and it will be contradictory. As you know, this happens very frequently. So I think it's important for the non-pathologist community, clinician community, to pay attention to immunohistochemistry, especially these biomarkers that are related to cancer, in particular breast cancer. So I'll not go into very much detail, but one of the main reasons that this quality control issue is important is because the ER, PR, HER2 results that we receive from pathology labs, there is a lot of error, like 20 to 30% mistake. So it could be false negative, could be false positive. And it happens in advanced countries as well as low or medium income countries such as Bangladesh. So this is a universal problem, and most of these problems we can address within our resources. So we should pay attention to these things, these issues, and I believe it's up to the oncologists to create these circumstances where the laboratories adopt quality control practice. Otherwise, this thing will be going on in a vicious cycle. Patients will go to a lab, they will get results that are not reliable, and then they will move from one lab to another lab, and finally they go abroad. We don't want this scenario, right? I'm sure you all agree with this. So, there are three important markers for breast cancer. One is ER, which is positive in 70% of cases of invasive breast cancer. PR in 60% cases. And there is a HER2, which is positive in 15-20% cases. So the HER2, it's a quite important thing recently, and especially for the oncologists. I know that probably very soon you'll have to treat HER2 low cases, ultra low cases. And if your laboratory is not reliable, if the results are not dependable, then there will be mistreatment, malpractice, and there will be a lot of issues with the patient. So I think we have still almost a year of time before the HER2 test the drugs come into practice. So we should try to fix the problems that in the immunohistochemistry lab as soon as possible. So I'll not go into too much detail of these slides. I think the slides are not. Slide কেটে যাচ্ছে নিচে এটা তো কালকে ছিল
স্লাইডের বাইরে চলে গেছে
হ্যাঁ হ্যাঁ
এডিট করে
হ্যাঁ
স্লাইডের বাইরে চলে গেছে
এখন তো সব স্লাইড এডিট করতে
স্যার আসলে সব স্লাইডই কম বেশি এরকম হয়ে আছে স্যার
কারণটা কি
সেটআপে একটু ডিস্টার্ব প্রবলেম হয়ে গেছে তাহলে এটা সেটআপ করবে স্যার এইভাবে সেটআপ করতে সময় লেগে যাবে
মাঝে থাক ওকে স্যার
স্যার এটা যেমন হয়েছে
আচ্ছা
এখানে
হ্যাঁ
এই স্লাইডটা ঠিক হয়ে গেছে
না এটা এখান থেকে শুরু
এখানে এখানে ক্লিক করেন স্যার
এখানে
প্রেজেন্টেশন মোডে স্যার দিস
আবার প্রথমে চলে গেল
নেক্সট এটা না স্যার
Okay, sorry for the interruption. I think some of the slides were not in the correct place. Well, anyway, so we talked about ER, PR, HER2, and then of course KI67, which seems to be very popular in Bangladesh. Especially a lot of oncologists, I think, request KI67. However, the role of KI67, it was discussed yesterday. I don't think there is much role in treatment. But probably, it might be still requested by oncologists. We do not, in our practice, we don't get KI67 requests, and it's not done routinely unless the clinician specifically asks for KI67. And one of the reasons is the standardization of KI67 reporting or cutoff is not very clear cut even after like 15, 20 years. So its role is still, it's not very clear. Okay, so very briefly about the HER2. The HER2 was interpretation was quite straightforward until last few years. It was HER2 negative, HER2 equivocal, HER2 positive. If it was HER2 equivocal, then you just order fish, and then if it's positive, then you treat. If negative, then it becomes HER2 negative and no treatment for trastuzumab. But now with the discovery of HER2 low category, HER2 ultra low category, now it has become important for us to report HER2 immunostains very carefully. So again, this brings us back to the issue, the importance of oncologists' expectation from the laboratories. So if the oncologists are going to, they will be treating these HER2 low, HER2 ultra low patients with the drugs, the NHER2 or whatever the other drugs. So you have to be very careful that the treatment is proper, so that you're not like under-treating or over-treating these patients. Again, very briefly, I will talk about the problems of immunohistochemistry, which I'm sure the pathologists are all, they usually know about this, but some of the aspects should be, I think, addressed by the surgeons, especially the pre-analytic phase. So if you have a specimen that coming out of the OT, it should be as soon as possible. I mean, if you have formalin, should put in formalin as soon as possible. Don't wait for the someone to pick up the specimen and then send to the lab after a few hours. The tissue gets degraded outside of formalin. So if you want a good report, please put your specimens in formalin as soon as possible. Keep formalin in the OT, and as soon as it's out of the patient, ask your assistants to put in formalin. So once in formalin, it can wait for hours. You can send it later, next day. It doesn't matter. But without formalin, you send it to the lab, and it might stay like that over the weekend for days, and then the result you get back is totally unreliable. Okay, so that's the pre-analytic part that is very much dependent on the surgeons. There are other aspects that are important, but mostly for pathologists. So the pathologists who do these tests, they have to be very careful about their protocol and make sure that the protocol is being followed very religiously every day by every technician. It's not you do one test, one protocol today, change it a little bit, do it another way tomorrow, because that will affect your results quite significantly. So what is the most important part or the aspect of immunostain is the pre-analytic part. Right? So pre-analytic, there was actually even before the specimen, when the specimen comes to the lab, the laboratory people should make sure that the specimen and the patient matches, right? So the name, the identifier of the patient, the organ, the surgery, and the organ received should match. If you've done a hysterectomy and the specimen is labeled as spleen or vice versa, that will cause a lot of problems. So that is very critical in the OT. So everything is labeled properly when it goes to the lab. Put in formalin as soon as possible. It's better not to wait for too long. And so, as I was saying, the importance of formalin, poorly fixed tissue under-fixed or over-fixed is also bad for immunohistochemistry. If you rely on immunohistochemistry for your diagnosis, for your treatment, then you must make sure the tissue is properly fixed. You have to make sure that there is enough formalin to fix the tissue, and you're not waiting hours to put the specimen in formalin. So this is I'm showing some example of what happens. So here is a immunostaining. This is of course not the surgeon's interest. In the laboratory, if you cut slides, no, sorry, this is cold ischemia. So sorry, this is back to the surgeons again. So you have to put formalin in your specimen. Otherwise, you see from 0 hour to 4 hour outside formalin, the immunohistochemistry staining is getting weaker. So if you just imagine if it's 24 hours, I think you will not get any stain. And it might be reported as triple negative breast cancer. Tissue thickness is also another issue, cutting, the way the technicians cut. So the pathologist should be aware of how the technicians are working in the laboratory. Tissue thickness can also impact on the staining pattern. And ultimately, there will be over-interpretation. The role of different antibodies is also important. If one laboratory uses one clone and then a second laboratory uses another clone, then of course the results will be different. So it's better not to use too many different clones, because every clone has its own protocol. So if you have 4 different laboratories with 4 different antibodies, and you don't know how many protocols, then of course the results would be very contradictory, and the patients will be frustrated. This is one example of what happens. The picture on the left side has one clone, picture on the right side has another clone. So just look at the difference. Okay, so this is what happens if you overfix. You keep in formalin for a very long time, 8 hours versus 104 hours. So, there is a difference. So underfixation, overfixation is both are harmful for the specimen. Okay, I'll skip this. So as I mentioned before, the fundamental challenge that is coming for the pathologists and oncologists is the detection of HER2-low breast cancer by immunohistochemistry. Because immunohistochemistry is the only assay that will diagnose HER2-low. No gene expression or NGS will do that. So you have to be sure that your laboratory is, giving you reliable results. So I think that even for the oncologists, they should pay attention to their labs. So this is the drug that will come very soon, TDXD or NR2 for HER2-low. I will not go into details of this. So one of the ways that laboratories can improve is quality control, quality assurance. So if they participate in external quality assurance, this will improve the biomarker testing of their laboratories. So external quality assurance means you can participate in overseas programs, UK, Australia, USA. That's one way, but it's expensive. So what you can do is you can share slides between labs within the country, or send the same slide to different labs and compare the quality and interpretation. So that will be also quite helpful to assess the quality of your individual lab. Okay, I will skip this. So so the laboratories which perform HER2, even for, I don't know how many labs do gastric HER2 here, but if you're doing HER2 for breast or stomach or some other, or like even in the gynae cases, it's important that the protocol is standardized, because HER2 will be, it's very important stain now, and it has a very widespread treatment. So now the question is, is it possible for Bangladesh, the laboratories in Bangladesh, to adapt to all these strict quality assurance programs? The likely answer is no, right? So we cannot adapt to all these strict, stringent criteria. So what should we do? But before we go into that, Sir William Osler hundreds of years ago said, the standard of your medicine actually depends on your pathology. As is your pathology, so is your medicine. So if you look at the state of pathology practice in Bangladesh, that actually reflects the state of medicine practice in our country. So if you want to improve medicine, we have to improve pathology practice. It might sound a bit strange to most of the non-pathologist clinicians here, but this is true. And I'm sure that you all have experienced a lot of problems with pathology laboratories in Bangladesh. And I'm not the first one to say this. You have heard this before. So it's not the problem of Bangladesh. There's a lot of countries in like Africa, Kenya, Uganda, Zimbabwe. These are not very highly developed countries, but they have come together, and they have been practicing pathology as a group. A group in a sense that the quality control, they have very strict quality control programs that has been implemented with the help of overseas bodies. So, which brings to the point is, if we think that the standard of pathology practice, and I was just discussing with Dr. Tashabul Haq right now, the private laboratories in Bangladesh actually have the capacity to build up this standard. And I think that at least the private labs, the big labs, they should come together and come up with some guiding principle to regulate themselves. Because since the government is not regulating the laboratories, we have to regulate ourselves. We have to have a body that implements some of these practices. So I think this is a very critical time now. We have waited long time. At one time we thought ER-PR HER2 is just a laboratory test like urea creatinine, but no, it's not. HER2 at one point it was very straightforward. You fish, no fish, no. But now it's getting complicated with the low HER2. So we have to come up with some principles. So what are the challenges in Bangladesh? So infrastructure, of course, is a challenge. There's low infrastructure, we have poor infrastructure, we have to get most of the labs outside Dhaka, I don't think they have, most of them will not have automated immunostainers. So the option is manual, but of course there are problems with manual technologies, but if you don't have automated machines, we have to adopt and standardize the manual immunohistochemistry. So there is also a shortage of trained pathologists and technicians. So just last month, I was in a workshop, was hosted in IPGM and BSMU. There were pathologists from 8 or 10 different hospitals outside Dhaka. Most of them, actually all of them, none of them had immunohistochemistry facility. There was one hospital, one pathology lab, they don't do histopathology. They do only cytopathology. So just imagine the state of pathology practice in our country. So that, the laboratory that doesn't do histopathology, then of course the question is what is the role of that department, right? So, we have to pay attention to these minor details. It's not minor, but we have to look at these things. So, of course, there's an issue with buying reagents and supplies. This is another issue with formalin, and this has been discussed many times. It's difficult to buy formalin in Bangladesh, like sulfuric acid, hydrochloric acid. But these are medical grade items, so I think the government should make some exemption for laboratories to purchase quality reagents. Now, I know one lab was doing a very simple stain, mucin stain, but they couldn't do it because they can't get the reagent. So I actually supplied the reagent from my lab, and then that improved the staining. So I think the pathologists or even the oncologists, they have to bring to attention to the government that we need to make some exemptions for pathology labs so that they can practice freely. So as I was saying, the manual practice, manual staining should be implemented if automated stainers are not available, at least in small hospitals. In district levels, they can start with 1, 2, 3 immunostains, and I think we need to start somewhere. Otherwise, there will be overload of patients in the city, in Dhaka city, and of course we have to pay attention to capacity building. So a lot of technologists outside Dhaka, they don't know how to do regular H&E stains. They don't know, they know theoretically how to do immunostains, but never done it. So we have to train them so that they can do this. And the private labs probably can help this. They can have courses, paid courses, train people from outside Dhaka, and the technicians, even train pathologists who do not do report IHC on a regular basis. Once a year, they go to a workshop or conference, they see slides, and that's it. So we have to pull up the standard of the pathology practice, especially outside Dhaka. And the other way to do it is use of telepathology. Telepathology is quite available. Even using your iPhone, you can take a picture of your slide, send it to your colleague and get an opinion. So it's very simple now, actually. You can transmit your image, scanned image, with a link, and I can open the link from my phone or from my laptop. So getting a consult, second opinion on imaging slides is very easy now. So please do this, if you have to. We get teleconsults quite frequently from different countries. So it's nothing high tech now. It's quite simple. So I don't want to go into too much details now. So going back to immunostaining for the pathologists, although there's no pathologist here. So tissue fixation and processing is important. And immunohistochemistry protocol, there are some protocols that need to be followed very carefully, meticulously. There are different, as I said, there are three aspects of immunohistochemistry: pre-analytical, analytical, post-analytical. So we have to maintain all the protocols uniformly. What you do in the beginning of 2025, you have to do the same protocol end of 2025. We cannot deviate from the protocol. You have to be able to do it blindly. I'm talking about the technicians, not, of course, not the pathologists. So, you see the three phases of the laboratory: pre-analytic, post-analytic, and there are different protocols. So at the end, there are millions of protocols that you can adopt, but it's not possible, right, to have so many protocols. So it's better to stick to one protocol. Make it simple, it will give you good results. So again, cut out. As the government doesn't often appreciate the importance of diagnostics, it is taken for granted because the private providers have done this job. So now if the government doesn't step up to help the diagnostic lab, the private labs have to do it now. I think this is the time, because in my opinion, from my observation, the private labs are more advanced than most of all of the government labs that I've seen so far. So the onus is now on the private sector in Bangladesh to develop pathology and medicine, by extension. So what we should do is we should, have multi-center validation of protocols. All laboratories, private labs come together. If the government labs want to join, invite them, but if don't, we should do it ourselves. We should do IHC versus FISH concordance. This is going back to HER2 staining. So to make sure that you do an audit of all your stains, ER, PR, HER2 stains over 1 year. If the oncologist can ask the pathologist that I want to see your ER, PR, HER2 staining frequency in the lab, so that you know that the result that you're getting from the pathology lab is accurate. Is the ER being more positive than usual or less positive? So this is actually quite critical for the oncologist and the surgeon to know what is the trend of the reporting of ER, PR, HER2. And by extension, you have to do a long-term quality monitoring. So you should continue for 1 year, 2 years, 3 years, 5, 10, 15 years. So that you can look back at 2020 and see what was the trend at that time. ER positivity, was it 70% or 50%? In 2025, has it gone up or has it gone down? So this will give you an idea. It's very simple. It's not much work to do, but it gives you a very clear idea about your laboratory practice. I think that's the end of my talk. Sorry, I think I took too long. Thank you very much for your patience. No. So just before I start.